Thanks, Joe. Hi, everybody. I did actually send a slide in. I don't know if you've got it there, or shall I bring? Oh, brilliant! Thank you so much. Yes. So just gonna, sorry, change my viewing so I can see my talk. There we go. I'm Catherine Hale. I'm going to be talking mostly about sort of like statutory social care and people with chronic illness. I was a social care user myself back in the 1990s. I've had my chronic illness for over 3 decades, and when it was really acute in my 20s, I couldn't feed myself, wash myself, couldn't go to the toilet, and I had a social care package. But years later, when my condition was less severe, my needs were kind of harder to grasp because they were invisible and poorly understood because of the nature of my condition. And the social care system completely let me down as a disabled lone parent and let down my children too. I became a disability activist and realised that my experiences as a person with chronic illness were common. In our online communities, people with different diagnoses share the same experiences of fatigue, limited energy, and pain. And we also share the same experiences of social injustice and oppression. Actually, a lot of that oppression is based on disbelief and denial of our impairment and our disability. So in 2017, I founded the Chronic Illness Inclusion Project because our experiences and voices as disabled people weren't reaching decision makers. And so policies and services such as social care completely fail to meet our needs. So what do I mean by the chronic illness community? Well, 1 in 3 disabled people has impairment of stamina, breathing, or fatigue, according to government data on impairment types. That means kind of different types of disability. But with chronic illness inclusion, we developed the term energy impairment rather than stamina, breathing, or fatigue because we find there's just too much negative cultural baggage around the terms of fatigue and stamina. So as you can tell from that data, many disabled people experience some element of energy impairment, but when it's the main feature and the most restricting feature of a condition, we call it energy limiting chronic illness. And you'll probably be familiar when I mention things like ME, fibromyalgia, lupus as kind of classic examples of that type of chronic illness. Now, if you ask people with energy limiting chronic illness or ELCI, what's your vision for social care reform and independent living? Actually, most people don't know what independent living is as defined by the Disabled People's Movement. And that's because most of us aren't getting any statutory care or support at all, let alone one that offers self-directed support or choice and control over our assistance, as the concept of independent living means. Of course, part of the reason for that is cuts to local authority budgets that have decimated social care funding and services for all disabled people. But there's something more going on for people like me with chronic illness, and that's what I'm going to talk to you about today. So you might be thinking at this point, isn't it just because our needs are not severe enough that we don't qualify for social care support? So I want to share research with you that will hopefully challenge that view, based on a survey I did with Action for ME in 2015. Of course, ME is just one type of ELCI, but it's an important example because according to several peer-reviewed studies, ME appears to be the most debilitating of all chronic conditions, more so than stroke, MS, or schizophrenia, for example. Now, in our survey involving over 800 people with ME, we found that 97% had needs for care and support that made them potentially eligible for a care package. And if you can see the chart I've got on my slide, lists daily living activities. And according to the Care Act, if you have difficulty with 2 or more, you may be eligible for support. So 97% of our respondents had these 2 or more difficulties, and yet only 6% had a care package. And in fact, only 16% had even had a social care assessment. So even in today's climate of austerity, this suggests an exceptionally high level of unmet need in our community. Now, of this tiny percent of people with ME who got through the barriers and got a social care package, more often than not, they were met with a service that's completely inappropriate to their needs and even damaging to their health. And I'm talking about something called reablement, or sometimes called enablement, which is a short-term package of support that aims to decrease your dependence on care and increase your independence. Now, reablement is a fine idea for people following a stroke or an injury or an operation, but it's a completely wrong-headed approach to energy-limiting chronic illness. because people in our community typically ask for support only after battling for years to remain independent. And then they find they get a care package, but it consists of being pushed to do more for themselves. And even worse, reablement means you have to do activities of, say, washing and dressing in the short time frame of a care visit with no rest in between, which for someone with severe ME can cause a relapse because we can only do one small activity at a time and need long periods of recuperation. So our respondent said that being put through reablement was actually worse than getting no care at all. So a major factor in this neglect and this mistreatment is a misunderstanding of energy impairment. And this applies, of course, not just to ME. And it's not surprising because when you look at the language and concepts of disability used in the care sector and in policy making generally, it's very striking that energy impairment and any description of chronic illness are missing. So I put these categories down here, which are sort of typical categories for impairment, which divide disability into mobility, mental health, sensory impairment, learning disability, autism. Those are the kind of the basic categories of impairment that you usually find. But there's nothing that captures our experience, despite the fact that, as I said, 1 in 3 disabled people has impairment of stamina or fatigue. So it's little wonder that when it comes to social care assessments and care planning, our needs are just not acknowledged. Energy impairment is different from other forms of impairment. It involves the rationing of extremely limited supplies of energy to achieve basic tasks of daily living in a way that other people completely take for granted. Tasks like washing, dressing, or preparing a meal. We may be able to do any of these given tasks, but only at the expense of being able to do another one. So what care professionals don't understand is that we may be able to perform all the basic tasks of daily living, but not on the same day or even in the same week, or we might be bedridden for several days afterwards from the effect of performing just one of these tasks. There's also no understanding of the cognitive dysfunction involved in ELCI. So for half our survey respondents, cognitive problems meant they couldn't even navigate the bureaucracy of assessments and planning for social care. Yet they didn't qualify for independent advocacy because they didn't have a recognised cognitive impairment like dementia. There's also no understanding of the sensory intolerance and sensitivities involved in ELCI that can make care needs extremely complex and challenging. All these experiences and needs are ignored and discounted because we don't have a formal label that identifies us as a cohort of disabled people with distinct needs. Closely tied to this, there's what we call systemic disbelief. So 60% of people who've been turned down for a care package attributed this to disbelief and dismissal of their account of their needs by the person assessing them. Disbelief is also a formidable barrier when it's internalized. 2 in 5 respondents said they couldn't ask for support because they were too anxious about being judged as undeserving, faking, or otherwise not genuinely disabled. We call it systemic disbelief because it's rooted in the way medicine constructs knowledge about the body and disease and the authority that medicine has over other areas of society and social policy. Within medicine, experiences like fatigue that can't be measured are systematically erased, or they're given labels like medically unexplained symptoms or functional somatic syndromes or other variations on this, which are actually little more than euphemisms for old-fashioned notions of hysteria. And once labelled in this way, we're stigmatised and our credibility as witnesses of our needs is undermined. And our symptoms are put down to laziness or malingering, or what they like to call false beliefs. So this ignorance and lack of understanding of energy impairment and the systemic disbelief of our needs kind of self-reinforcing and mutually perpetuate each other. And we need to challenge both of them if we want to improve social care provision for people with energy limiting chronic illness and support people to have more meaningful and socially connected lives instead of living in the deprivation and neglect as so many are today. We need to start by identifying and counting ELCI and energy impairment in the same way we do with other impairment types. Only then can our needs be incorporated into assessment systems and planning for care. We need training for care managers and care workers so they understand the impact of our conditions and what kind of support we need to live as fully as possible. And of course, we need an immediate end to the use of reablement for all types of chronic illness. Underpinning this, we need the social care system to move away from medicalised models of disease and these kind of stigmatising constructs of psychosomatic medicine. We need to listen and give credence to the lived experience of patients and service users. But beyond statutory care services, I want to end with a broader vision for inclusive communities that I'm really excited about at the moment and want to share with you. Because a lot of people with chronic illness are disconnected from their local communities and potential networks of support because they're housebound. And with the COVID pandemic and lockdown, one unexpected but positive outcome is that society became more accessible to those of us who define ourselves as housebound, because everyone in the world practically has been housebound, so has had to find ways to meet and connect through technology like we're doing today. And suddenly we've become included and been able to participate in our communities in a way that we weren't able to before. And people with chronic illness are afraid that once lockdown restrictions end, we're going to be excluded from society once again and lose all that benefit that we've gained, ironically, during the pandemic. So with remote access technology, and I'm talking about things like Zoom, there's a real opportunity to sustain the inclusion of this invisible group, if you like, of disabled people with chronic illness, because the pandemic has shown that the technology is workable, and we need to develop ways of integrating remote access into local communities once they start meeting face to face again, so that we can be meaningfully included and take part in our communities, even for those of us who are going to remain stuck inside once the lockdown ends. And that's the end. Thank you very much.